Thank you organizers for giving me this opportunity. And so I'll be discussing efficacy and safety of first-line Lorlatinib versus Crizotinib in patients with advanced ALK-positive non-small cell lung cancer. So this is an updated analysis of data from phase 3 randomized open-label CROWN study, which all of us are familiar with. So this first publication was in 2020 by Alice T. Shaw. So this CROWN data was published and it was a breakthrough with the huge advancement over Crizotinib. And now this was an unplanned updated analysis from CROWN study at nearly 36 months. So this was recently published in Lancet Respiratory Medicine in April. So the CROWN study we are familiar with, stage 3B, 4 ALK-positive non-small cell lung cancer. So Lorlatinib versus Crizotinib was studied and primary endpoint was PFS. And so there were 296 patients, well randomized 149 to 147. And so these are the baseline characteristics. Females were 56% in Lorlatinib, then white versus Asian 48 and 44, and majority were never smoker or previous smokers, and majority was stage 4, and nearly 1/4 patients were having brain mets at baseline. And so just to recollect the previous study, so the 12-month PFS difference was 78% versus 39%, and median PFS had not reached in Lorlatinib with HR of 0.28. And so this was by investigator 80% versus 35% and has a ratio of 0.21. And so all the subgroups had huge benefit, and Asians had slightly less than non-Asians, but otherwise if you see smokers versus non-smokers, everybody had the Lorlatinib arm was better. And if you see the overall response rate, 76% responding versus 58, and with an additional 13% stable disease with Lorlatinib, and median time to response was nearly 1.8 months. And if we see the intracranial response, that was 66% with measurable or not, all the population, and with measurable brain metastasis, 82% in Lorlatinib responded versus 23. And so the intracranial time to progression, so if we see the Lorlatinib curve, that is almost straight and at the top. And so median time to CNS progression was 16.6 months in Crizotinib, and in Lorlatinib it was not reached. And this is the OS at that time. So median OS not seen at that time. And adverse events leading to permanent discontinuation was just 7% and 9% in Crizotinib arm. And so these are the adverse events. So we had hypercholesterolemia, hypertriglyceridemia, edema, weight gain. So these are the prominent side effects with Lorlatinib. And with Crizotinib we see edema, diarrhea, vision disorders, nausea, vomiting, and raised liver enzymes. So these are the prominent side effects with Crizotinib. So now coming to this update, so at 36.7 months, the PFS remains significantly longer. If we see at, let's say, 18 months versus 24 months versus 36 months, so majority of these patients continue to benefit, and with PFS nearly 64% versus 19%. And so PFS still not, the median PFS still not reached, and overall response rate 77% versus 58%. And again, all the subgroups continue to benefit in favor of Lorlatinib. And time to intracranial progression was significantly longer with Lorlatinib, so 92.3% versus 37%. And intracranial time to progression in patients having baseline brain mets. So here again at 36 months, 73% patients had, so was still having benefit, and whereas in Crizotinib, all of them have progressed here. So this median PFS not reached versus 7 months. And so without baseline brain metastasis, so 99% versus 50%. So here again, Lorlatinib is showing a very significant and good response. And to summarize the overall intracranial response, so 77% versus 58% in favor of Lorlatinib. So in patients who had any brain metastasis, so majority of them were responding. So 65% versus 18% in Crizotinib. So if we look at the adverse events, so majority, take some time. Okay, in interest of time, maybe I can talk, and even without slides we can discuss this. So the adverse event profile was, it continues to be same, and the Lorlatinib arm, majority of patients remained on the on treatment. There were dose reductions, so from 100 mg come down to 75, come down to 50, but patients continue to be on treatment, and the permanent discontinuation rate was nearly 7% again, even at 36 months. So majority of patients who benefited, who were not having major problems, they continue to take the treatment, and the benefit also continued. And even in Crizotinib arm, the discontinuation was not very high, it was less than 10% again. And the safety, other side effects also continue to be seen. So we see a lot of hypercholesterolemia, hypertriglyceridemia with this, but this is not leading to additional cardiovascular incidents. So there is no additional cardiovascular risk. These are well manageable, and the cardiovascular risks were not increased on Lorlatinib arm as compared to the Crizotinib.
Dr. Sachin, there's one here on your left.
Should we? Yeah.
Sorry. So there's some time indicating of the thing. So the cognitive dysfunctions in the CNS toxins is about 20-25% if I remember the data. 20-25% of cognitive. So how do you manage? What do you de-escalate the dose? When do you start to reduce the dose? At what point? There will be some cognitive dysfunction. I had one patient who had got hallucinations and started shouting there was fire, those sort of things. So when do you de-escalate?
Yeah, so for any toxicity which becomes grade 3 or grade 4, we tend to come down to first 75, and so I personally have not encountered major toxicities wherever Lorlatinib I have used, and but we have freedom to cut down to 75 followed by 50 if required, but majority patients would tolerate this thing. So these are last few slides. So in the intention to treat population, at 36 months, the PFS is 64 versus 19, and in patients with baseline brain metastasis at 36 months, 50% versus nil, and without baseline brain mets, 68% versus 23%. And so just to summarize, at 36 months, median PFS not reached versus 9.3. Patients alive without progression at 3 years, 64% versus 19. Patients with baseline brain mets alive without progression, 68 versus 23. And time to intracranial progression at 3 years, 92 versus 38. And 99% patients remain free from brain mets at 3 years with Lorlatinib. So it has got wonderful results in brain metastasis as far as brain mets are concerned, because majority of patients would develop brain metastasis in their natural history in ALK-positive non-small cell lung cancer. So this again, so this point needs to be considered again whenever we choose any drug for this particular malignancy. And after this progression, only 22% patients on Lorlatinib versus 70% on Crizotinib had some subsequent therapy. And these are cross-trial comparisons. Brigatinib, the median PFS is reached 24 versus 11. Alectinib, nearly 35 months versus 11. And Ensatinib, 26 months versus 12.7 months. and not reached for Lorlatinib. So this is all I have to say in this presentation. Thank you.